그리고 딴 데 쓴 봅시다.
Good morning, everyone. My name is Park Eung-dolum. Today, I will present case of ECG conference. Dr. Dong-ho, can you interpret ECG?
There is there is multiple PPTs and assume that the PPTs is maybe it's not LDD. So maybe the origin from RD. And looking at lead one and the ABF, axis goes to northeast. So maybe post receptor or RD, I'm not sure.
I don't think it's northeast. Should be positive. Reflects south. Right? So RB origin. RB above. Still we don't know. Because the red artery, pulmonary artery, and the aortic root change. So okay. So
Sinus rhythm, it requires a specified QA and defect stimulation. Heart rate is irregular, heart rate is around the PR and course duration is normal minutes. There is two music, ventricular bituminous ventricular reflex. I think this previous iteration is Q1. And particularly right ventricular upper parts.
can you specify the location? What patient's location? Please.
Are you
Are you sure? I'll be a program. 80%. Okay. So, Kyo, do you have any other ideas? You should stay loud.
So I think this the origin and when it's abroad, what years it is indicate second location and three area is inferior accident. So inferior accident means inferior position and before our transition even is particularly our transition steps will be two possible and so this will be bigger position. If we see the photos is the 2, 3, 4, 5, 6 a little bit skin on that. 2, 3. So I think it is RBUD subject.
RB outflow tract imperceptor. So that is use opinion. Okay, finally, after care point. Like this potential, the focus of this. We see and also CPT.
We can see the three degrees positive and weak. AVR is negative, but the AVL slightly spiking, so. I think it could be possible in the outward pressure. Focus likely not that higher. The transition side is, I think, the T3 to so I think it could be possible in RBOT or RB bundle, but we should
Yeah, so Dr. Huang suggested, Dr. Huang too suggested the IB in the infundibula. Okay, also, I guess that we need to map the IB inflow track and potentially some left side aortic cost area. So Dr. Huang is here. How are you, sir? How was your Tanzanian trip?
I am doing well.
Can I hear you?
Good to see you, everybody.
스피커 좀 들어줄래? 이제 안 들리거든요. 잠깐만요.
I can hear you, but you cannot hear me? Can you hear me? My speaker is on. Hello,
선생님 다시 말씀해 볼 수 있어요?
can you hear?
네, 근데 굉장히 작게 들리는데 마이크를 좀 키워봐.
Okay, I did increase my volume all the way up. 안 들려?
잠깐만요. 여기 선생님 저의 얘기하는 거 잘 들리시죠?
Yes, I can hear you very well.
마이크 문제인 것 같아서 잠깐만 기다려 보십시오. 여기 마이크가 다른 마이크잖아. 그래서 스카프 마이크도 있잖아. 연결이.
야마로 이렇게 스피커가 스피커. 저거
네, 선생님 이제 말씀해 주십시오.
잘 들려요?
네, 이제 고쳤습니다.
Okay. All right. Good to see you, everybody. Obviously, I am back safely from Africa, so happy to be back home. So you have a EKG here that we discussed last time. You need to make a habit of see everything in this ECG, not just looking at the PBCs. So what do you think about this P wave? Patient in sinus rhythm, obviously. Is lead to P is rather a little bit taller and durations are perhaps a little bit wider. So that may suggest that the patient may have a possible biatrial or either right atrial enlargement overload. And you're talking about the PBC morphology, axis and on that. But before that, somebody can tell me in lead 3, why the QRS complex keep changing in sinus rhythm? Those kind of things are more interesting for you to learn, not just diagnose the PBC where they're coming from. So explain to me why the lead 3 after the each PBC QRS change. What's the mechanism of this? Anyone?
Respiratory change. Ambulatory reflex.
What's happening here is that after PVC, second complex PI is slightly longer. Can you see that? And then after the second PVC, third sinus PI is even longer than first beat. Is that has to do with this QRS complex? Do you see it? Can you point the arrow for me? Then maybe you can point the arrow for me, then you can see better. Lead 3 and the rhythm strip. Who is presenting this?
박음돌.
Oh. No, okay. Can you hear me? Yes or no?
Yes.
Okay, so then point to lead 3. Arrow, go to the point the arrow, please. Lead 3. Follow. Yes, that bit and your PVC and the next bit. Next one, yeah. PI is longer, QRS changed. And then you had another PVC, next one. And then another sinus rhythm following that, right? And QRS changes too. So you got 3 different PR interval, 3 different QRS complex. Those things that you need to learn, not to just diagnose PVC and your stage. What's the mechanism of this? We talked about this before. If you studied it, you would remember this. Why is QRS getting narrower and axis changing with the longer PR?
Ventricular phasic autonomic change.
No, would not explain the last PP interval though, because your last P wave and that followed, there's no PVC, just sinus rhythm, and PR became normal again. Yeah, that PR got shorter again. So it is not a ventricular phasic P wave. No, this is not. So what it is, you have to measure the PP interval, okay? Make sure they're same, first of all. In my eye, looks pretty same. That means this patient has what? No VA conduction. So they may be retrograde concealment of the aviodynamic conduction area, and subsequent PR got longer, QRS changed. And then last, even longer, got even longer, with even narrower QRS complex. So then you have to wonder, the sinus rhythm, patient's sinus rhythm, you see, wider QRS complex with a shorter PR. Yeah, that guy. This is a little bit of a sort of intraventricular conduction block, aberrancy, or something else going on in sinus rhythm here? Probably some sort of a, fascicular block going on here. And then with the PVC modulation, you had the retrograde peel back, and then you conducted the last bit with a longer PR, the normal QRS complex. So that's one observation. Second, you need to tell me what happened with there's a triplet in the middle of a tracing, correct? You get the last bit, very last bit of that triplet bit. They look the same? Then for subsect first 2? Different. Amplitude got taller. What do they mean? That is, has to be what? So you measure again PP interval. So that QRS complex just preceded by P wave, just before. So this is a sort of, yeah, right there. No, yeah, that guy, yes. No, next one. That one, yes. S segment is slightly changed. There's a P wave there. You can see better in the lead 1, actually, P wave. Go to lead 1.
Lead 1.
One.
Lead 1.
Lead 1. Come back to triplet. Come right there. You just passed that. You passed the P wave right there. That P wave partially conducted, resulting fusion. So this is a PVC by Germany interfering with the normal sinus conduction with the probably underlying some sort of fascicular block that peel back and recover to totally normal sinus rhythm. And you have a PVC last triplet bit is a fusion bit. Now, you're debating whether this is alpha or is a left side or right side and so on. One caveat that I want to tell you, if you look at the lead AVL, what does that PVC looks like? AVL, it's like a biphasic almost, right? Correct? It's biphasic. That means what? It's almost perpendicular to the AVL. what that would be, perpendicular that would be left side or right side? Initially positive and negative. It's almost zero potential. Yeah, it's all biphasic, PBCs. Did I tell you where it might be? 90 degrees from AVL is what? Lead 2, almost. That's why tall was R wave lead 2. And then you have a relatively narrow looking PBC precordially with a transition V1 to V2. Correct? So that would be people talking about where? Septal? Probably a little bit low septal. So infundibular also maybe low septal right outflow tract PBC. That may be what is going on here. Anything else you want to tell us? Anybody has any comment? Anything else?
I would like to mention about the T-wave inversion in B1 to 3. So
Yes.
most of PVC, if echo is normal, we see the idiopathic VT of PVC, but because B1 to 3 shows T-wave inversion, so we need to differential diagnosis for all the phase of ALBC also.
Right.
And
But-
also if you look at the coupling interval of PVC and non-sustained VT, it looks exactly same. So, and the non-sustained VT shows a different QRS morphology and their RL interval also slightly changed. So yes, the mechanism of PVC could be a DAD, trigger that trigger.
Could be. But that precordial T-wave inversion that you mentioned also would do favor for right atrial overload, looking at the lead 2 tall P wave. That probably what's going on together. But I think your comment is well taken. That's certainly yes. But then I think this patient doesn't have a conduction, so the intermittent fusion be going on as well. So any other comment, please? So you guess this is old man, old guy, young guy?
Uh,
No, you're not supposed to say that. We are talking still, okay?
how old
Love
is
you.
a 68-year-old female.
Oh, I did not ask your age. Am I asking based on the ECG?
Uh,
Don't tell us the age. So Dr. Bach told you a lot of information already. So that should be guessing what might be the potential age of this patient and all that. So if this patient heart is a little bit more flat because the lead 1 has a talus R wave in sinus, and then 2, 3 progressively lower. So heart is lying down, really consistent with maybe with the even right ventricular, enlargement, rotating the heart to the left. It's possible. So until develop all this can be young guy, right? Because old guy. Okay. You can tell us what you have to say now, Dr. Lum. Tell us what we know. Go ahead.
Sinus rhythm ECG.
Okay, let's go back sinus rhythm ECG, please. You're too fast. Okay. So Dr. Park's comment is well taken. Take a look at the T-wave inversion all the way to V4 precordially, right? And then you have a relatively tall R wave with V1 to V3, okay? And then you got P wave is still a little bit taller in the lead 2. And a little bit slow heart rate, okay? Anything else? And then you don't see sinus arrhythmia in this patient, do you? Right? Lead 2 has no sinus arrhythmia, all consistently same heart, almost same heart rate. Bottom tracing, pocket lung, rhythm strip. Yeah, heart rate is steady, right? That's a good or bad for you fellows when you don't see sinus arrhythmia. That's a good sign or bad sign? When you don't have a sinus arrhythmia, I mean you don't have an autonomic modulation. That tended to be bad. Tended to be, not worse, not a bad thing. I mean, older age and so forth, they tended to have a less sinus arrhythmia. Okay? Let's go. Okay.
This is a 68-year-old female, and she has experienced recurrent syncope, and also she describes nocturnal episodes of chest heaviness that awaken her from sleep with partial relief upon awakening. And she has no past medical history, and she is taking Concord 2.5 milligram. Her chest X-ray shows cardiomegaly. Echocardiography revealed ejection fraction 69% and normal-sized cardiac chambers and diastolic dysfunction. And variable Holter shows VPC 26%. Exercise test is negative, and heart CT shows there is no evidence of coronary artery disease. And she underwent EP study, and non-sustained VT was ablated with RVOT, posterior septal site, and LCC RCC commissure. This is after ablation ECG.
So why did you ablate the both sides? Do you know why did you have to ablate both sides, posterior septal and the LCC, RCC commissure? Is coming from the septum? Is that what you're trying to say?
Have the answer.
No.
Is she my patient?
Yeah.
Last we ablated.
Yes, last.
Actually, you didn't show the VFECG, focal point CG.
VFECG?
It has a history of recurrent syncope.
Yeah.
And frequent PVC muscle VT. And I asked her to admit because the frequent PVC muscle VT and the patient experienced recurrent syncope. So it's a risk of sudden death. But she refused it. So I asked her to check the wearable ECG 1 week. And then in wearable ECG, it shows the documented VF. Course of the bomb lasting 30 seconds. Okay.
Did you do EP study on this patient by any chance?
No.
VT induction?
Yeah, we tried,
Okay.
but the VT was not useful.
Okay.
Because the VT disappeared in the EP lab, but after using the isoproterenol, we could see the consistent monomer PVC. So I tried map the RB outflow track, actually inflow track, posterior septal side. Very short outflow track. And it was very broad activation, always activation side.
Right.
So I put the microcatheter, and the microcatheter was not that early. So I mapped the left side process. I tried to ablate the oldest one. I don't remember, the left side was always the right side, but it is almost the same time. So I tried to ablate with 35 watt, failed. Left side 35 watt, failed. So probably, and the 3D map shows that there's kissing lesion in between PCRCC commissure and the RB outflow tract posterior as map. So I used the hyper 40 watt, 45 watts, and eventually I eliminate. And
Okay.
my question is, she experienced recurrent syncope and the documented torsade form lasting 30 seconds during sleep twice. And after procedure, she didn't show anything. She didn't show one single PVC, but I wonder when she needs ICD or not. That is my question.
Now, Dr. Bob,
Yes.
do you think that the cardiac MRI would be helpful to you here?
But because of insurance coverage issue.
But I'm not talking insurance coverage. I'm talking academically. We're talking.
I think the cardiac MRI might be very helpful.
Yes, because you got a 12-lead ECG shows a precordial inversion T wave all the way up to V4. And then you have documented this episode of pulmonary VT non-AF, BF. That's but yet you don't have any EP study suggestive of substrate or either etiology of this polymorph VTVF. So question is that the patient may need a little bit more workup before you put a ICD on her. And you said the patient has no coronary disease, no other explanation other than diastolic heart failure. So question is, this diastolic heart failure has to do with some sort of cardiomyopathy? Is it possible?
Possible.
Yes. So basically, you have a patient who has EKG-wise, at least, some suggestion of patient has looks like a biventricular involvement plus atrial was mentioned one. Suggestion was maybe restricted cardiomyopathy. Any of those patterns could be possibly explain this. So I think MRI, I think would be academic sense, this would be very important approach, next step for fellows. Obviously, economic vision you can, we understand that, but I think for teaching standpoint, you should be thinking about it.
Probably the currency shows QT prolongation, QTC over 502.
Yes.
Milliseconds.
That's yes.
Yeah, so can you show me the sinus ECG? Even though in this ECG, post-ablation ECG, doesn't show the significant QT prolongation, but the Q-wave shape is a little bizarre. So I requested the gene study. It is partially covered by insurance.
I see.
Yeah, I asked the patient and family, let's wait for the result of the study. If it is negative, probably I should ask the cardiac MRI.
So
But
if I may say something quickly, if you look at the lead 2, I wonder even there is some J point elevation there.
yeah,
The small notching there, end of QRS. You see that guy? No, just before that. End of QRS. Point, lead 2, end of, yeah, that guy. It's very small, but I think there is some notching in there that is something suspicious. But obviously non-diagnostic, any of this that we're talking. But certainly 68 years old female patient with a history recurrent syncope with the precordial T-wave inversion all the way out. So you have to work this lady up before you commit her to the ICD.
I think that her T-wave shape.
But the type looks like long type 3.
Yeah, because
But,
of Porteous syndrome, there are 3 type 1 to 3 long syndrome. So different T-wave morphology, and this patient experienced the torsade bar at nighttime during sleep. That is typical the history of long sleep. And there's almost a flat, and the later peak of QA is characteristic of both type 3 long sleeps. But actually after ablation, QTC changed to be normal.
But yeah, it's sinus rhythm ECG, clearly patient has a biatrial enlargement. Look at the lead 2. You got tall P with the notching at the end of it, on the upstroke. Yeah, that guy.
So anyway, Dr. Wang, you favor to implant ICD if the cardiac MRI shows a late gadolinium enhancement. Well,
regardless for protection, since you did not find any EP study reason and explanation why having syncope with the polymorph VT, you have to, for the treatment standpoint. I don't know whether there's any other way you can save her.
But
can treat it legally, but
torsade bar,
yeah,
seeded by same morphology of PVC, this patient.
Well, that is a debatable issue. If you has, let's assume that this patient is a primary VF. Primary VF ablation is not a guarantee that the patient going to have freedom from the sudden death. There's no data. We have a very limited studies, but then, if this is, we are talking outflow tract, PVC trigger, polymorphic VTVF, this is even rare. We do see a polymorphic VT originating from left ventricle, vesicles, and those guys, most of them has an ICD already, but then some of them primary VF patient, we did ablate clear-cut potentials and all that, but this is not that murky. The reason is that the primary VF patient, you can induce VF, demonstrate that's a mechanism of tachycardia. You don't have a mechanism of tachycardia here. You just have a PVC, non-sustained VT. Now, Holter monitor, whatever, shows that that PVC is the same as the polymorphic VT trigger. I'm not sure that's, you can say all that it is, cover your concern about the sudden death. That worries me. Okay?
So thank you very much. Because I invited US, the prestigious scholar, Professor Homnak Chair, so he's waiting for his lecture. And, let's close the ECM conference here. Thank you very much.
Thank you.
감사합니다. 대박나 선생님 혹시 들어가게